Hello, everyone. Good evening. Before starting our presentation, uh, I introduce myself. My name is Sonia Ayaz, and I have completed my Bachelor of Science in Nursing from Aghan University, and I have a vast clinical experience. Now, currently, I am working in Aghan Hospital as a registered nurse, as well as working as a research coordinator. Now we will move our topic. Today topic is GBS in pregnancy, which is a, maternity topic, which is a high yield topic in the NCLEX. So be prepared and listen carefully. Our learning objective is the by the end of the high yield topics, which is a maternity in 20 minutes review, student will be able to define and classify, differentiate group B streptococcus. Uh, this is the bacteria infection from sexually transmitted infections and understand its transient behavior. After that, recognize the screening protocol. We recall the exact gestation windows period, universal culture, and describe the proper swab collection techniques. Identify prophylaxis criteria, evaluate maternal clinical scenarios to determine which labor clients require intrapartum IV antibiotics. After that, apply pharmacology and assess risk, state the first line and the alternative drug regimen which are giving in the during labor, and monitor the newborn for a potential critical complication occur after GBS. First of all, we discuss about what is the GBS. Can you tell anybody regarding the GBS if you know? Um Okay, the group B streptococcus is a gram positive. The name is a group B streptococcus, which is a gram positive infection, which is a bacteria and opportunities bacterium, and commonly found in our normally microflora, which is our in the most commonly present in our hand, our skin, like. Present in our rectum, vagina, cervix, or urethra as well. So during the labor, we will assess this GBS before the time duration. We will talk in the upcoming slides. So the maternal colonization is asymptomatic in approximately 10 to 30% of a pregnant client. Which is a happen GBS gram positive bacteria found in 10 to 30% of the pregnant women. And what the threat is happen in the infant. Most of the infant cause the dangerous infant disease like pneumonia and meningitis, while there is a no any harmful occur in the mother, because there is a normal flora for mother, but definitely the baby have a serious disease, which is GBS during the vertical during the birth, during the labor. And if the uh, infant is contact with this normal flora, after that it's occur the GBS. Now the high yield nclex secretor, which is GPS, is not an STI. Make sure you can teach the clients that the GPS does not result from the sexual activity to prevent unneeded relationship stress. So you can talk with the patient as well and clarify the concept. What is the transient flora? Transient flora is a GPS count vaccine or vein. And this is a testing positive weeks ago does not guarantee the client is currently colonized. It means not the previous have a colonized in 25 weeks. Now is 37 or 35 weeks. They have also currently also have a positive colonization is not a guarantee. but we need to treat if the patient is found in 28 weeks or 25 weeks. So definitely we need to treat in the during the labor, so we can save our infant. Critical, what is the critical here? It is the most vertical transmission during the labor can cause cataphoric, means very disaster to the newborn infants and neonatal, because there is a very serious illness which cause death even. Next slide is a timing, which is a particular timing regarding the GBS screening, which is 36 to 37 is the HILD. This is a HILD. So we need to understand this 36 to 37 weeks gastrations. So we this time durations we require the screening of the maternal or mother who are coming in our clinic. Universal routine cultures, which is the nclex questions, always test this window periods. Already told you all pregnant clients must be screened during this time, which is 36 to 37 of a pregnancy. And since the GBS status change constantly, like if a doctor is advised in 28 weeks or maybe 25 weeks to urine test, or they found GBS in it, so constantly the GBS status may be changed in 36 to 37. They not might be not to have a GBS in that time. So screening must be occur during every single pregnancy, or and regardless of a previously results, like a previous pregnancy they have a negative. Now we have not assuming that right now in next pregnancy patient has a no any GBS may result occur. Exceptions, if GBS is found in a urine bacteriuria earlier in this pregnancy, skip screening. They are automatically GBS positives and require IV antibiotics in during labor. Like if we have a patient have a test in a 30 weeks urine test occur, they have found GBS positive. So we did not again repeatedly GBS screening in 36 to 37 weeks. They also treat like they have a positive, and we need to give IV antibiotic as well during the labor. Now, how we screen swab techniques we see in this slide. The vaginal rectal culture, we have to identify how the nurse perform the procedures is a frequent NCLEX exam topics. So maybe they have give the multiple choice questions and you have need to the techniques most of the time they ask. No speculum means we need no need to use speculum during this swab test. This keeps the procedure quick and painless. So first of all, we need to do gently insert a single sterile swab 1 to 2 centimeter into the lower vaginal interiors. Second steps, this is a pass the same swab. That is the first we have to insert the vagina and take the sample. After that, that same swab insert to the anal sphincter, which is seen in this picture as well, and the which is rectum, and rotate gently. And after that, remove the cap and place immediately into the culture tube and send to the laboratory after labor. Now, next slide is who gets IV antibiotics in labor. First is a positive screening. Who have patients identify the GBS positive in 36 to 37 weeks, and they required IV antibiotics. And those who are GBS bacteriuria, GBS detect in the maternal urine as well. They also have a during pregnancy. They also required IV antibiotics in labor. Prior affect infant, like in the previous history, infant have a previous infant who has a GBS disease. So next pregnancy we need to treat as a patients in IV antibiotics during labor. Now, next slide is unknown GPS status protocol. Now we discuss about unknown because we know that patients who have a positive, so what we will do, and those who have a negative, what we will do in the upcoming next slide. We will see also uh, what we will do those who have a negative result. And now we will only discuss about the unknown GBS status, like patients have coming in a 20 30 weeks of the they have come and they have a labor pain starts. So what we will do, because in that time we cannot know identify regarding the GBS status, because the GBS status will be identified in the 36 to 37 weeks. So that's why this is the unknown case. So if the GBS status is unknown when the labor starts, administration empirical means penicillins, IV antibiotics, if the clients has any three risk factors like preterm labor. First of all, we discuss preterm labor. Like already discussed, delivery occurs less than 37 weeks, which is a higher infant risk who have a GPS may be positive or maybe not negative, but we don't know. So we need to give the IV antibiotic with this patient. Prolonged rupture of membrane, those who have a patients who have a membrane rupture and they have a time goes greater than 18 and equal to 18 hours before delivery. So we need to give those patients as well IV antibiotics during labor. The, Now maternal fevers, temperatures, who have a temperature mother, we have coming in a labor, and you have to find that the patient have a fever in that time. So we will also give these patients the IV antibiotics during labor, during labor. Now, when we not give the GBS and not IV give antibiotics is a C-section exceptions. When we have a planned C-sections with the intact membrane. With the intact membrane, we need plus C-section. So those who have a no labor pains and no, they have a planned C-section and intact membrane, the not does not require antibiotic prophylaxis, or even if a patient have a GPS positive, so they are not required this that patients are not required GBS and IV antibiotics during labor. I hope so. This point is clear. But those who have a planned C-section but rupture of a membrane, so and GBS positive, that mother need to give IV antibiotic to not give this to the infant. Pharmacology and drug choices. Our next slide is what is the priority? First line choice of drug here to for GBS is a penicillin G. Doses is 5 million unit IV loading dose, then 2.5 to 3 million units IV every 4 hourly until the birth. NCLEX indication, what is the indication? Is a drug of choice, and this is the safest drugs and narrow spectrums and highly effective drugs for GBS treatment, and alternative is the ampicillin. Ampicillins we are required 2 gram IV loading and then 1 gram every 4 hourly until the birth. Equally effective and backup if penicillins are not available. So we will give this alternative ampicillin. If patient have a coming in a mild allergy through the penicillin, so we will give the cefixoline. This is another drug of choice we are giving for patient, like the dosage is a 2 gram IV loading dose and then 1 gram IV every Q8 hourly until the birth. For the client with the history of mild penicillin reaction or anaphylactic reaction, so we will give these medications for cefaxoline. If patient have a severe allergy to the penicillin, so the drug of choice is a clindamycin or vancomycin. So clindamycin is are given 900 mg IV Q8 hourly, or vancomycins are given 1 gram IV every 12 hours. So the indication is a reverse for severe penicillin anaphylaxis or requires susceptibles. Neonatal complication. Now, what happened? The neonatal complication, if the patient, if the uh, infant is a vertical transmission, and during the labor, so they have a dangerous they have the dangerous infections, and newborns are highly susceptible for a transmission during the labor of the this normal flora is a contact to the baby, and then the cause is agar, which is GBS, because the mother antibodies are lack, and that lacking IgG is a very lack, so that's why they are not clear the mother GBS. Definitely, if newborn coming from the vaginal delivery, and then contact, and they are not, but if the mother are not receiving the IV antibiotic penicillin, so the definitely the baby and neonate infant will cause this GBS. And this is a big three, just like infant infections can quickly lead to devastating sepsis, and if we are not treating, or we are not able to treat this sepsis and blood stream infection, so definitely the infant will die, and which is the cause is pneumonia. After that, the and or meningitis is occur due to the GBS, which is very dangerous in for the infant. And the golden window is intravenous IV antibiotics. Not, we are not giving oral antibiotics. We are giving IV antibiotics. Must be given to the mother at least 4 hours before delivery. At least 4 hours before delivery, because we need to see the therapeutic levels in the baby circulation. So the baby is prevent for that GBS. Nursing care and NCLEX tips are in this slide we will discuss. Now, first is verify admission GBS status. Your first priority is that you have to find that whether is the patient is GBS positive or negative, or patient is unknown. So we will check the patient swab results, and or check for bacteriuria history test, whether they have check or not. Initially, IV early administration penicillin immediately upon labor or a membrane of rupture. We already discussed about this for prophylaxis. And monitor the newborn, assess the signs. We have find who have occurred GBS in a unit, which is a sepsis. First of all is a hypothermia, and after that find the respiratory distress, tachypneic, and grunting. They have uh, patient breathing, and they have the noise is coming like grunting, and poor feeding, baby is not feeding, and after that patient lethargy. So this is a critical sign you see in the newborn who have a GBS. So sometimes NCLEX trick you and trap you regarding the oral penicillins or antibiotics taking before labor begins, or are completely ineffective. If we are giving the oral antibiotics or antibiotics so before the labor, so definitely they are ineffective, because first of all we are giving antibiotic through orally, which is not good for this bacteria, not kill this bacteria, or completely ineffective before giving labor. Intrapartum IV treatment is the only standard of care to give in this to treat the GBS, and we are giving during active labor, not before labor. Okay. Now we see the NCLEX challenge questions. We already discussed about in the previous slide. So we will solve this question. A client at a 28 weeks gestation presents with a urinary tract infection. The urine culture reveals group B streptococcus GBS. What is the priority nursing action? So first is advise scheduling a vaginal rectal screen at 36 weeks. Think about that. We are doing vaginal rectal screening 36 weeks if already identified in 28 weeks. Instruct the client to take oral penicillin G until delivery. This is a not a primary care treatment. We need to give IV. So this also is not a correct answer. Document that IV antibiotic are required during labor. This will correct because we need to identify the document. At least we need to document in 28 weeks when they have identified, and during the labor, so we have definitely we need to give the IV antibiotics for this patient. And definitely D is wrong. Plan for a prophylactic schedule C-section at 39 weeks. We cannot do that. Okay. So the correct answer is C. So the bacteriuria rules is that any GBS found in the maternal urine at any point during pregnancy presents a high maternal colonizations, or no rescreening needed if the patient is find any infections in a 28 weeks or maybe 29 weeks or maybe 30 weeks in the urine test, or swab culture, not a swab culture, but urine test. The bypass the 36 or 37 vaginal or rectal culture or swab automatically receive the partum IV penicillins. We need to give that patient as well. NCLEX trap you and sometime trip this for oral antibiotics taking during pregnancy do not clear GBS from the vaginal and rectal tract for delivery day. Intrapartum IV therapy is only safest and a safe standards practice. Now the next question is the NCLEX challenge. Question is first we need to select all that question. This type of also questions coming in the NCLEX. The NCLEX on a labor and delivery is reviewing client files. Which client will require the administrations of intrapartum antibiotic prophylaxis? Select all that apply. So first we will see the one GBS positive status currently in active labor at 39 weeks. So definitely we need to give this medication. Okay, prophylaxically. Now second one is GBS positive undergoing planned C-section with the intact membrane. So the those patients who have GBS positive, we already discussed about that. And undergoing C-section patient have a planned C-section with no intact membrane. So no need to give them a prophylactic antibiotic. Third answer is a GBS status unknown. So definitely we need to give those patients who have a unknown currently delivery at 35 weeks. So definitely we need to give the antibiotics for this patient. GBS for answer is 4. GBS status unknown membranes ruptures in more than 20 hours or 20 hours ago. So definitely we need to give antibiotic as well. GBS negative status in a labor with a maternal temperature. If patient is a negative, but the patient have a temperature during labor, so definitely we need to give the IV antibiotics, penicillin, definitely for prevent newborn for GBS. Now we review in the last what we will discuss in our previous slides. GPS urine exceptions for we will understand what is the GBS, and the time duration of the collection of a swab is 36 to 37 weeks. And we learn about the techniques, and the four at least 4 hour maternal penicillin window time period we need to definitely we could give in active labors, not before labor. So during labor we need to give these penicillins and start the penicillin during active labor. And maternal risk factors, which is a preterm and pre-rupture of membranes, which is equal or greater than 18 hours, or if the maternal have a fever, so definitely we need to give the penicillin to save the infant from GBS. Thank you for everyone.